Hello, this is Chris Calkins. Welcome to my final presentation. I've chosen a case study where the clinician was interviewing a woman for homicidal and suicidal ideation. To accomplish our objective, we're going to use the tripartite model, which consists of three dimensions, which are A, the universal, B, the group, and C, the individual. Then we're going to compare that to evidence-based standards. Those are applied suicide interventions and skills training, otherwise known as ASSIST, which prioritizes the safe for now principle and has least restrictive measures, and then counseling on access to lethal means, which is also known as CALM, and that prioritizes removing the means, not the person, via negotiation. Before we go much further, I think it's really important to talk about what ASSIST and CALM are. So ASSIST, Applied Suicide Interventions and Skills Training, is an evidence-based program. It's sort of like American Heart Association, like does CPR, but this is for suicide prevention. And it's from a company called LivingWorks out of Canada, and it's been shown to be highly effective empirically. So it's a whole procedure. It's a 2-day intensive course that you can take, and it is intense. And I teach this, and I've had many mental health professionals in my course, but also many police officers and paramedics and all kinds of teachers, all kinds of people from different walks of life. It's an intervention program. So the premise is on recognizing things, recognizing when somebody's at risk for suicide, asking them in the right way, asking them directly, are you thinking of killing yourself? Actually, first you premise it with telling them why you think that, and then you ask them very directly. You don't say things like, you're not thinking about, are you? Or you wouldn't do anything stupid, like, because what you're saying is, I can't handle it. Don't tell me. I want you to lie to me. So it has to be asked very directly. And then as we've been practicing in class, you need to practice silence at that point and just let them speak, even if it's a long pause. And once you identify that somebody's at risk for suicide, you need to establish a rapport. It's all about rapport building. We call this the therapeutic alliance. And people mistakenly think that there's only two choices for people who are actively suicidal, and that's life or death. But that's not true. There's actually a third choice, and that is safe for now. Can we agree you'll be safe for now? And getting to that objective can save lives. We can work on the long term later on as therapists, but in the crisis, in the acute moment, you want to drill on safe for now. That's your sole objective, is to get them safe for now. And that does have elements of means restrictions and safety plannings and all this, but that's further down the road. First, you have to establish rapport. Listen to them, hear what's going on. There is therapy in listening and therapy in silence. So, safe for now. And it's cooperative in nature. You give the person what dignity, another theme in our coursework, what dignity and self-worth you can, and let them have as much control as you are able to afford them given the circumstances, and get them structures in place to keep them safe, and draw on resources available and their sources of strength and what helps them and the people that help them. These are all things you can do. So it doesn't always culminate in calling the police or calling an ambulance or calling a hospital, or rather taking somebody to a hospital against their will. Sometimes it does in extreme cases. I'm not saying that's not something that should never happen. I'm just saying I think it happens too much. And that's a lack of comfort with people who have suicidal ideation. If we put everybody in the hospital right now who's experiencing suicidal ideation, we'd probably clog the hospitals up with people. There wouldn't be any room for anybody else with any other kind of a medical issue. So in suicidal ideation, there's a spectrum. You have ideation. It can progress to an attempt. It can progress to a death. But there's less deaths than there are attempts, and there's less attempts than there are ideation. So I think the first thing as clinicians we should do is think about the statistics and take a breath. That doesn't mean you shouldn't worry, but take a breath. Put it in a perspective. And that is, I've given you such an abbreviated version of assist. And during an intervention, we're looking for something they call a turning point. And so a turning point is a word like if only, or two words, but. If. That means that there's doubt. That means that it's not the decision has not been made. The death is not a foregone conclusion. You can say, I heard you just say if only. That means you're not certain. And then explore that. And again, a lot of listening. So that's assist in a nutshell. I highly recommend the class. It changed the way I practiced as a paramedic almost completely. I'd like to talk a little bit about calm before we go on, so you have some framework and some of the essentials or premises of how it works. So first off, calm sees the myth and calls the myth out that if somebody's means is taken away, they'll just find another way to kill themselves. That has been proven untrue by much research. And so you might ask yourself, where's the proof in that? And this is something that I've heard even clinicians utter before, which, again, it is not true. So how do we know this? Well, the Sydney Harbor Bridge, the Empire State Building, and the Eiffel Tower, for starters. In those areas, suicides by means of jumping from a high structure were prolific and a problem. So these were former what we call in suicidology hotspots for suicide, places where a lot of suicides occur. So if suicides increase or stay the same, the premise is, after all, they'll just find another way to do it. So if that's true, then the suicides in that area will at least stay the same number-wise, because after all, the person just found another way to do it. And in every case, that was demonstrated not to be true. Suicide rates went down when guardrails and barriers were erected in those structures, and that it debunks part of that myth. The other thing that happened was that in the United Kingdom, there was a prevalence of suicide by overdosing on Tylenol or acetaminophen. They call it paracetamol there. But what happened was they enacted legislation to outlaw the production of acetaminophen in anything except for a blister pack. You could no longer buy it in large bottles. So the time that it takes to pop open those blister packs is enough to delay the person so that their ideation changes, their ideation level. We'll talk about that in a second. And after that legislation, suicide rates went down markedly in the United Kingdom overall, because they didn't just find another way to do it. It turns out that people are pretty married to their plans for killing themselves, and while there are exceptions, those are rare. So this brings us to the idea that ideation, or thinking about suicide, is a dynamic process, not a static. Think of it like a pain scale on 0 to 10. 0 is no pain, no ideation, and 10 is horrible pain, worst you can experience, worst ideation. So people can be, you're not just on a 4 and you just stay there forever. You're not just a 4 on an ideation. And it's like you either are not 4 anymore or you are 4. No, this is a fluid dynamic process. So you could be a 4 on that scale for 5 minutes. You could be a 10 for 1 minute. You could be a 1 for 5 weeks, 5 months, 5 years. You could be sliding back and forth continuously. And research shows this. That's why means restriction works. Because in the case of England, even the action of taking the extra time to pop the pills out of the blister packs decreased suicide. Because ideation changed levels during that time. So when you're talking to a patient who is suicidal, time is your friend. Even 30 seconds can save a life. Any kind of a delay. So the time you spend building rapport, talking to them, developing a safety plan, and then disabling their plan, right? So if you have a firearm, what are you going to do with that? Is there somebody who can hold it for them? It's called a safekeeper program. Can it be locked up? Those kinds of things. And people might say, oh, well, if we lock it up, they'll break the container open, those kinds of things. But the point is it slows people down. Rationing medications can do the same thing to help with overdoses. Limiting the places where people can tie things for ligatures or hangings. So, policing a room and looking for those spots, which isn't easy to eliminate all those points, but you can do a pretty good job if you put your mind to it. Hospitals have programs like this because hospital suicide rates are actually pretty high. The Joint Commission on Accreditation of Hospitals put out 2 separate warnings to all hospitals in the United States saying there's too many suicides in hospitals. So that's an interesting thing when we consider sending people to the hospital who are experiencing suicidal ideation. The CALM class, by the way, is available free online by the Suicide Prevention Resource Center, SPRC. And if you go to sprc.org, you can go take the free course. It's evidence-based. I highly recommend it. Every clinician should have it, regardless of practice. I think more than clinicians should actually have it. Unfortunately, this was a video basically of how not to assess somebody for suicidal ideation. And that is because the clinician's failure to recognize specific individual and group identity dimensions led to a coercive kind of risk-aversive intervention that violated the evidence-based best practices, those being assist and calm, which have been empirically proven. In the way of a profile for our patient here, she is a female, approximately 47 to 55 years of age. The video, it didn't exactly say her age, but if we take the clues of when she's due to retire, who she works with, how long she's worked at her current place of employment, it's about 47 to 55 year age estimate. Her race is white, sexual orientation, heterosexual, and lives in the United States. Her profession is a military test systems engineer, and from the conversation we can garner that she's what we call a C-level executive. And the reason they call that C-level is because of things like CEO, COO, CFO, etc. So C-level executive, she's fairly high up in this military test systems company. Our patient is seeing the psychologist because at her work, she started an affair with the CEO, and who is a married male, and she basically was found out, that relationship came to light, she was kind of shamed. The affair was blamed on her, and basically she ended up leaving employment, and then because of non-compete clauses, she can't get another job for a specified amount of time, because she can't just go get a job doing the same thing. That's the nature of a non-compete clause. And it also was revealed during the interview that she owns a revolver, and she does admit to nearly using it Monday on herself, but instead she called a friend and chose not to use the firearm on herself. So this kind of thwarted love triangle kind of thing going on, and she's getting cyber shamed. So people are calling her a slut. They're slut shaming her, so to speak, and blaming it on her. One of the clinician's grievous errors, if you will, was really to do with identity dimension, which is C, and that's understanding individual uniqueness. In this case, the, so to speak, weapons engineer versus the suicidal patient. So this patient is not a layperson. She's a military test systems engineer. She stated that she gets professional pride from fire and smoke and missile tests. She refers to her revolver as a security blanket. And so the error here is really not adhering to the calm principles, which is negotiating a means restriction by understanding the patient's relationship to the weapon. So the biggest failure is the clinician interpreted the security blanket comment solely as a symptom of instability or dependency. He really failed to see that for somebody who's a weapons expert, the gun represents competence and control, not just death. So this is akin to when I've done research on law enforcement officers, military personnel, even ranchers in Wyoming, where firearms are part of their life. They're a tool, they protect, they are basically like in another, as somebody in Wyoming told me, another appendage to use. And if you don't believe me, just try to get a police officer in the United States to surrender their weapon while you're treating them, and we'll see how that goes. In fact, I would say that the majority of them don't seek help because they're afraid that they are going to lose their weapon, and their weapon is their job, right? If you can't carry a weapon, you can't work. So these are important things to remember. So this provider really didn't consider who his patient was. So instead of negotiating a transfer of the weapon with calm, he mandated a transfer of the patient towards the hospital. And that misinterpretation of the gun solely as a threat, he failed to negotiate based on her specific relationship to the weapons. That he's comparing her to somebody else who doesn't have that kind of a job or isn't in that kind of a culture, if you will. The next failure of the clinician really had to do with identity dimension B, which is gender, sex, gender, and status. So we've got a feminine female, and we've got a C-level executive for a large company who's really facing a double standard. The person she had, the CEO she had an affair with, is not suffering at all. She sees injustice, and she loses everything. She's got the double standard going. People are branding her as a whore, quote unquote, a home wrecker, things like this. While the male seemingly gets off. Her primary emotional will, if you will, is a total loss of power and autonomy. And for a C-level executive, that's quite significant. And so the clinical error as far as assist goes is that the assist principle is to use the least restrictive approach to empower the patient and restore some control or agency the best that you can. Because when people don't have control, they do whatever it takes to get control often. So the failure here is really when the patient attempted to leave, the clinician used coercion. I can call the police. I can have you brought back. So basically what he did is he duplicated the group level oppression she was already experiencing. And he did that by threatening police involvement to a woman who was suffering an injustice and about to take back what little dignity she had left. The third error made was really an issue that had to do with identity dimension A, which is kind of the universal aspect. So what we're talking about here is universal survival instincts versus institutionalization. So humans have an innate survival instinct to turn to safety. So the patient demonstrated this universal trait. I almost took it out, but I called Carrie, her friend, instead. So that means something. So there was a resource blindness going on with this clinician. So the assist principle is identifying and utilizing existing resources. So that could be people, coping skills, etc., for what we call a safety plan, which, by the way, should be differentiated from a safety contract. Research shows signing a contract saying I promise I won't kill myself is worthless. It is completely worthless. But planning for what to do if one feels suicidal is empirically based, and that's been shown to be helpful in work. So the failure here, the clinician ignored the fact that the patient already successfully safety planned herself essentially on Monday. He dismissed her friend Carrie as a safety asset and insisted on the hospital as the only safe option. So biggest failure here was that the therapist, again, used coercion, threat of police, the hospital, instead of collaboration. He again reinforced her lack of power and shame. So I don't know if it was the intent of this video to show what not to do, but that's what this video did. It was a classic textbook case of suicidal ideation and what not to do. What to do that's almost the opposite of empirically based evidence. So now we come to the so what can we do plan. How do we correct this? What's the right way to do it? So there's 3 steps here. And the first step is about validating individual identity. So, you could say as an engineer, safety protocols better than anyone. Right now, your internal systems are overheated. We need to secure the weapon to follow the safety protocol. How this adheres to the calm principles. You're kind of speaking her language, if you notice. Step 2 is empowering her group identity. Look, you've had your control taken away by your company, and just I don't want to take any more control away. And let's make a plan where you decide where the gun goes, so we can adhere to the assist, which is that safety planning piece, and giving her what control we can, and practicing that means restriction, right? Without using coercion. I don't often give people, as a paramedic, I don't often give people choices that I can't live with. So I give them what control I can. So an example is, if I really need a blood pressure, I don't ask somebody, can I take your blood pressure? If I can't accept no for the answer. So what I do is say, would you like your blood pressure taken on the left arm or the right arm? And this is a similar principle to that. Lastly, step 3, utilize universal resources. So, you could say you were strong enough to call Carrie on Monday. How about we call her now to hold that weapon so you can stay home, just temporarily. When you're feeling better, Carrie will give it back. And that adheres to the assist, calm principles. So these are the 3 steps that you could use to correct what happened here, if we could go back in our time machines and change it. So in conclusion here, what we saw, or what I saw in this video of the practitioner interviewing a patient for suicidal ideation or homicidal ideation, it didn't go so well, and it was almost an anti-empirical approach, if you will. He never even asked directly, are you thinking of killing yourself, until she gave more hints, even though he suspected that ahead of time. He didn't follow evidence-based practices of assist or calm, and he didn't understand who the patient was, that that sex and gender and her professional status and all these things had to do with her predicament, and it just being misinterpreted. Misinterpreting that the gun was a risk, and it led to unnecessary hospitalization potentially, instead of a security blanket or a coping thing that could be temporarily mitigated with means restriction. True safety comes from restoring the patient's agency, not threatening them with police or hospitalization. The clinician was technically competent in asking about the gun, but culturally, he was pretty incompetent in understanding what the gun meant to the patient. Remember you didn't see the video necessarily, but there was a quote, "I don't have any pride left." And that's the ultimate result of a coercive approach. And that's a risk for suicide. She was compensating. She'd already basically she de-escalated herself. She self-de-escalated by contacting her friend and then seeking help. And instead of seeing that effort, it was pushed back into oh my gosh, I have an acutely suicidal person who is not coping well, and he basically re-escalated the situation potentially. So anyway, I hope that you've gotten something out of this presentation, and that you can use a tidbit or two of this for your in your career as a mental health clinician. I wish more mental health clinicians knew more about suicide as I travel the world and do presentations and interface with my peers from across the world, many of whom are mental health practitioners. They tell me themselves, mental health professionals don't know enough about suicide. They know all about the mental health parts, but the suicide part is scary, because if our patient dies by suicide, oftentimes we think that is a result of something we did or did not do. So it tends to get avoided. And it's kind of this, let's not talk about it too much. It makes us uncomfortable. Yet it's a huge problem worldwide and in the United States. Take care. And again, I hope this helped.